All right. Well, we're going to talk just a little bit about neonatology tonight and just go over briefly what a paramedic's responsibility and role is and some of the things that you might see on a call with a neonate. Probably most of the time this would be post-delivery, but we're going to go over some of the things just so you can be aware and know what you might expect if you're on a call like this, and also so you can pass the exam. All right. A couple of things really quick. Babies go through several stages of physical and emotional development. And so those stages are neonates, we consider anything less than 1 month old. Newborns or newly born infants are those babies that are within the first few hours of life. So that's kind of the very beginning stage of the neonates. And this is regardless of their gestational age. So if you may have a baby that's 6 weeks premature, they're still going to be considered a newborn or a neonate for that 1 month. And then after an unscheduled delivery in the field, we always need to keep in mind that we're going to have at least 2 patients, mom and baby both. And we can't forget about mom because she still has some pretty dire needs. And we also have baby to take care of. And that is under the assumption that we only have 1 baby. So sometimes with multiple births, we end up having 3 patients. If dad passes out during the delivery, then we have 3 or 4. So we have to keep that in mind and plan accordingly. So if there's other resources that you can get pulled into that, if you know that you're going to have multiple deliveries or a difficult delivery, we might want to do that. Okay. This is a picture of a full-term newborn. And we talked a little bit about this in class. We saw a little quick video, but you can see here they're kind of purple. I suppose delivering them, they look not very big. For mom that is delivering them, they feel huge. But they're kind of got a cheesy covering on them. They are super slimy and slick. And hopefully they're grimacing and crying like this little one is. Okay, so when we take care of a newborn, okay, we're going to follow the same priorities that do with all patients. So those ABCs are our primary concern. And they don't differ in priority than an adult. It's still the airway, breathing, and then circulation. So the things that do change is going to be our rates and some parameters that are there. But we still have to complete our primary assessment first. That still is a priority. And keep in mind, honestly, guys and gals, that the majority of newborns, like 99% of all newborns, require no resuscitation beyond, the main things that we're going to do anyway: suction their airway, stimulate them, and keep them warm. That's really the big things. If we can do that, do it well, and do it in a timely manner, we're going to have a successful outcome most of the time. Okay, so this little slide, of course, makes a liar out of me before, but 10% of newborns require assistance to begin breathing at birth, okay? That does not mean they need resuscitation. They just need to be stimulated to breathe, okay? 1% require extensive resuscitation measures. That's that 1 in 100, okay? Rarely are medications indicated in newborn resuscitation. Our biggest enemy there is hypoxia and hypothermia. So medications aren't really going to fix those. And therefore, we need to be aggressive with our airway management and our warming. So as our birth weight decreases in our babies, so if you get a tiny baby, they're going to have more issues breathing, more issues keeping warm, more issues adjusting from the intrauteral state to the extrauteral state. So keep in mind, if you've got a big baby, it's a harder delivery on mom, but generally those babies do a little better than our babies with a low birth rate. And I'm talking significantly low, 5 pounds or less. Okay. As soon as I can get my slide to click here. Okay. So we're going to determine newborns at risk. Hopefully, before we deliver or during delivery, we can start asking some questions. Considering antepartum. And antepartum care is the care that mom got during the pregnancy, okay? Because that care that mom gets also is the care that the baby's going to get. So that's going to include prenatal care that she got from a physician or a healthcare provider. It's also going to include her lifestyle. Was alcohol involved in her pregnancy? Was there drug use involved in her pregnancy? How old is mom? What's mom's nutritional status and how has that been through her pregnancy? Lots and lots of things to consider here. And then we're going to want to know as much as we can about the intrapartum, and so that's the during delivery factors. What has happened? Do we have a situation where we've got a limb presentation? Has mom's water broke 2 days ago and we're just now delivering? Has mom had a seizure during delivery? Has mom been sick during delivery? Has she been pushing for 20 hours and just can't have this baby? So there's lots of things that we want to consider both pre-labor and during labor. So got to make sure that our ambulance carries our basic OB kit and that has the resuscitation equipment for newborns. That can be newborns in the 1 pound range all the way up to the 10 pound range. So we've got to make sure that we know what's in there and that it's going to be enough to cover the various sizes of babies that we may have. Then we're going to plan our transport in advance. So when you get paged out to a woman in labor, that is the perfect time to start deciding where you're going to go. So mom may have a physician someplace and a hospital that she would like to go to. If we can get her there without breaking any protocols and without it being a bad decision, I say let's do it. But if baby presents abnormally or not responding well, if mom's hospital is a distance away and you're going to pass 3 very viable hospitals to get there, we need to think about that. If we've got a baby that's not responding well, we want to think about who's got a NICU. And that may exclude some of our rural hospitals. So we may want to think about, reflying. Children's Hospital in Omaha does have their own ambulance service. It travels with a paramedic and a NICU nurse. They can fly if needed as well, and they bring their incubator and all of that stuff with them so that the baby can stay warm, and they have all the equipment that they need. So they can come via ground, they can come via helicopter, they also can come via fixed wing. So think about that, think about your NICU options and what is closest to you. Make that plan maybe a little bit in advance. You have to follow your local protocols, obviously. And in this is a case, maybe medical direction is needed. I don't think any of us will deliver enough babies to be really good at this yet. So this is a case when contacting a medical director wouldn't be counted against you. Okay. So when our baby is in utero or in the uterus, obviously their respiratory system's not functioning. Okay. And when that baby's born, all of a sudden this respiratory system has to kick into high gear and start to oxygenate this baby that has never had to oxygenate before. So that's quite a switchover, and sometimes there's a little bit of a delay in that change, and that's where we have to be watching and step in if that happens. So 1/3 of the fetal lung fluid that's inside the baby's lungs, because it's just there. I mean, they've been swallowing it and breathing it, and 1/3 of that fluid is removed when that baby is compressed through the birth canal and it squeezes that chest. It does squeeze that fluid out of the baby's lungs, provided they have a vaginal delivery. Now, I'm guessing probably none of your in-the-field births are going to be anything other than a vaginal delivery, because if you're doing C-sections, I want to get with you and find out how you're doing that. So under normal conditions, our baby's going to take his or her first breath within seconds after delivery. So that gives us just a wee little bit of time to deliver the head. That head's going to rotate like we saw earlier, and then you are there with your bulb syringe, and we're going to suction as quickly as we can and pretty thoroughly. Okay, so our pathophysiology that happens during this is sometimes our babies are mildly acidic, and that in this case is good because it does help stimulate that breathing. The body kicks in breathing to try and reset our pH balance. The initiation of our stretch reflexes in the lungs. Once that baby's born and the chest is free, the rib cage can expand, and there's no fluid to go in there, so air comes into the lungs. So it's just that actual chest re-expanding after delivery is part of what drives the breathing. And then the other two big things are hypoxia. When our body its receptors don't kick in or start recognizing that they're low oxygen levels, it will kick in that breathing. And hypothermia is the other one. The body trying to warm itself will try and get more oxygen moved around because it needs to shiver. So with our first breaths, the lungs rapidly fill with air. Most of the time this displaces the remaining fetal fluid that's in the lungs. Sometimes you get babies that cough up that fluid. Sometimes it's pushed into the extracellular spaces. It is very important for us to facilitate those first few breaths. If we don't make sure that baby's breathing and breathing okay, that could very quickly lead to hypoxia, further acidosis, can lead to low heart rate, and eventually in pretty short order death if we don't do something about it. So those first breaths either get the baby moving on an upward path or it'll send him down a downhill path. So we need to make sure they choose the right path. So we're going to look for signs of respiratory distress, and we'll talk about those here in just a second. Okay. All babies are susceptible to hypoxemia, which is low oxygen, because they haven't done this before. And there's a lot of factors in there. The baby has been through probably more of a traumatic experience than mom has, because mom is experiencing pain in one area of the body. This infant has been traumatized from his head to his toes. And so depending on how quickly that baby bounces back and the condition he was when he started into that is going to play into how well he's going to respond to all of these factors that should stimulate breathing. So after that initial hypoxia, our baby should gasp for breath. Okay, he should start breathing and gasp for breath. If he doesn't, if that asphyxia, and asphyxia is defined for this purpose as irregular or disturbed respirations, or a complete absence of breathing with pallor and some cyanosis. So if our breathing doesn't quickly become regular, then we're going to quickly see respiratory drive fail. We're going to see heart rate falling. We're going to see the neural status decreasing. The baby will become more flaccid. Instead of pulling up in that fetal position and muscles tight, it's going to become more flaccid. Arms and legs are going to start to fall off to the side, and our muscular tone is going to go away. If you've got a baby that's in that kind of shape, you have a very, very sick baby, and the best thing you can do is stimulate breathing for this child. So that first little stage when they're born and they're not breathing really good yet is called the primary apnea stage. Okay? And 99% of the time, if we stimulate the baby, if we just take a towel or a blanket and just rub their back, or just take your fingers and rub his back. It doesn't have to be hard or vigorous, just something to kind of make him pull his muscles around and stretch his arms and legs and stretch his back out. And that's generally enough. If that doesn't work, then we want to suction again, and that sometimes will help stimulate. So if we have a baby that doesn't respond to that period of primary apnea, then we need to stimulate again. We need maybe to put some blow-by oxygen on, okay? Because if we keep the oxygen levels up, we're going to avoid the bradycardia. If we go bradycardic and we lose our heart rate, then we can put all the oxygen we want into this little one, but we're not going to get perfusion. So we want to make sure that we stay away from the bradycardia. So that pretty aggressive stimulation, if they don't respond to the first one, some blow-by oxygen to get some oxygen in them while their heart rate is still up enough to deliver it. And if that doesn't work, if we have that asphyxia going on, then our baby enters a period known as secondary apnea. And the secondary apnea is when we start thinking about resuscitation. So what you'll see in this baby is they take their last deep gasping breath, their heart rate, their blood pressure, and their O2 sats are all going to fall. And the baby will become unresponsive to stimulation, and he is not at that point going to spontaneously breathe. So we don't want to sit around and wait for them to start breathing. This is a time for us to get aggressive. So unless we do something quickly like CPR, this baby is going to die. So we're going to assume that apnea in a newborn is secondary. So we're going to start out a little aggressive. Okay, so we're going to rapidly treat with ventilatory assistance. Okay, if our baby does not respond to that and we are bradycardic, then chest compressions is the next thing. Chest compressions is going to do two things. It's going to get our heart rate up. It's going to increase our perfusion, but it's also going to stimulate breathing, because when we push on the chest, we push air out. When the little rib cage comes back, we're sucking air into the lungs. And remember, we said that that's one of the things that stimulates breathing right after birth. So sometimes that stimulation of CPR also stimulates them to breathe. 2% of our infants born are born with congenital problems. With the testing that is done nowadays intrautero, a lot of the parents know if their baby has got a defect, and some of them don't. Some of the like heart defects and things we don't find out until the baby is either born, or sometimes it's 2 or 3 months after they're born. They start having issues with growing and breathing, and they can't function and do like they should. And after some testing, they find out there's a congenital heart defect. So generally, when these congenital problems happen, it's in the first 3 months of development in the womb. And a lot of those babies, when they develop those abnormalities, the mother's body will spontaneously abort that baby. It's able to recognize that this baby is probably not going to be viable, and therefore that's when we get a lot of miscarriages. The body recognizes that there's an issue and aborts the baby. But some babies make it through that, and they have their anomalies and make it to delivery or to birth. But for the most part, these congenital problems is the number one cause of death in babies. For us as paramedics, generally, there's little we can do at that point except supportive measures, breathing, and see if we can get them to a surgeon in time to get it fixed. So heart defects are the most common in our little ones. And probably the most common is one, it's down at the bottom of this page, called tetralogy of Fallot. And that's basically 4 heart problems all in one. And that is the most common. This baby has got a port or a duct in his heart that doesn't close. He's got ventricular hypertrophy. I can't ever say this word. Hypertrophy. It's enlarged. He's got some stenosis in his veins, and he's got valves that don't work. So he or she. So there's lots of issues with that. Most of the time, though, we're dealing with either increased or decreased pulmonary blood flow or obstructed blood flow. Like a patent ductus arteriosus is the duct between, there's a duct in their heart because the heart itself is not pumping through the pulmonary vein and pulmonary artery to get the oxygen. In utero, the blood is oxygenated from mom, so it doesn't have to go through those veins. And so there's a duct there that bypasses that. When they start breathing, that duct is stimulated and it should rapidly close. If it doesn't, then we still have blood that's bypassing the pulmonary vein and artery, which is obviously going to keep our blood from becoming oxygenated. Sometimes we have septal defects. That septum that separates the atriums can be defective or have a hole in it. And sometimes we have septums in the ventricles, so our right and left ventricle leak back and forth between each other. So there's lots of different things. We'll talk about a few more as we go, but those are probably some of the main ones that we may see. Now, a lot of these babies are viable. They'll be, breathe, and they'll respond to your treatment, but you'll have a hard time keeping their oxygen saturations up. And that's where we're going to see babies that just don't pink up like they should. They may be a little more lethargic than they should be, and you'll have a hard time getting their sats up in that normal range. So here's the tetralogy of Fallot, and you can see, as we talked about, we've got all kinds of goodies in here. We have right ventricular hypertrophy. We've got a septal defect in the ventricles. We've got pulmonary stenosis, pulmonary outflow tract stenosis. So, and we've got an overriding aorta. So the aorta is not functioning like it should. Okay. Congenital. Other congenital abnormalities that we may find would be the transposition of the great vessels. And I've actually delivered a baby that had this, and then we eventually took him down to Omaha. So he took an hour-long ambulance ride with me. And he was actually a very big boy, I think about 9 pounds. But his aorta and his vena cava were hooked up backwards. So it caused all kinds of problems, and we couldn't, literally, he was on 100% O2, and he was sat in the low 80s all the way down. So we really struggled with him. I was able to follow along with him. He had surgery. They repositioned those vessels, attached them to the right places, and he did just fine after that. Played football in 7th grade and had a very normal, healthy life. So there's mitral stenosis, that mitral valve that becomes plaqued and bucked down and doesn't work like it should. We get stenosis in the pulmonary vein and artery, so we don't get proper blood flow through there. And I think we think of stenosis as an old people disease, but obviously it isn't. So we have to think about that with our babies. Same thing with our aorta. And then hypoplastic left heart syndrome. I think I looked this up. Oh, hold on, let me grab my notes really quick here, and I will get it for you. Give me 1 second. Okay, sorry about that. Hypoplastic left heart syndrome is actually a kind of what it sounds like. The hypo means less than, plastic is stretchy. So the left heart is drastically underdeveloped, and so it can't pump. And so the right heart the right ventricle, I'm sorry, the left ventricle is underdeveloped and can't pump well. And so the right ventricle is left with the job of pumping blood both through the pulmonary veins and arteries and out to the body. So what these babies end up having is medication to keep that duct from closing between the ventricles so that the right heart can try and compensate enough to keep this baby alive. These babies are looking at, if they're strong enough, extensive cardiac surgeries. Most of the time they need a heart transplant. So with technology like it is now, these babies are living longer than they ever used to, but it's still a very drastic situation for them to be in. Okay. Oops. So here's our aortic stenosis. We've got some stenosis in the aorta, and so we don't get that valve opening and closing like it should. So the blood has a hard time leaving the left ventricle and out to the body. So we're going to have a child that's generally hypoxic. Okay. Some non-cardiac congenital defects that we might see would be a diaphragmatic hernia, and that's where the diaphragm is actually herniated, so it's either got a hole in it or a weak spot in it that pushes the abdominal organs up into the chest cavity. So the diaphragm is not holding the abdominal things in the abdomen, it's pushing up into the chest, which obviously causes some serious issues with breathing. And then meningeomyelocell is how that's meningeomyelocell is structures of the spinal cord and the meninges, the lining around the spinal cord, are opened up and exposed. So generally we don't see this. It's inside the body. Some very, very drastic situations we might see, like the spine of a baby's back open completely through the skin and everything, but that's pretty rare, especially here in the United States. More third world countries see that. So with our diaphragmatic hernia, what we're going to see is we're going to see a baby that doesn't breathe well. So they'll be breathing very shallow and very quickly, probably not oxygenating well. If you listen to lung sounds, you probably won't hear any lung sounds in the bases, or maybe not on one side. That's probably not a pneumothorax. It very most likely would be a herniated diaphragm in this case. With the spinal cord exposure, depending on the extent of the damage, we may have some, and the location of that damage, you may have a child that is unable to breathe because their spinal cord is damaged. And then we have omphalocele, which is a herniation of the umbilicus. And the umbilicus is where that umbilical cord is going to attach to the baby, but their abdominal organs will herniate out into the umbilicus. So it's going to look something like this. And if you see this, we're going to treat it just like an evisceration. So we're going to cut and clamp the umbilical cord, but we want to keep this moist and warm. And so if you've got saran wrap, I'm a huge fan of saran wrap in the squad, because in case of an evisceration, and definitely in this case, that would be a nice thing to kind of coat that with some sterile water, sterile saline, and then put the saran wrap over it. It'll keep the dirt and the debris and germs out. It'll keep the moisture in. At the same time, it's clear so you can see through it and see what you're doing. This is a sick kid. We've got to be very, very gentle with this. Other things would be conal, I'm not even going to try and be able to pronounce this, conal atresia. And these are a bony membrane that kind of fits in there between the septum, or between the nasal cavity and the pharynx. So you can see here the white side over on the left is a membrane that's there that shouldn't be there, that should actually go down into his pharynx, and it does not. So it's things that are growing where they shouldn't. Obviously, we're going to have some airway problems with this, and these little guys are going to go in for surgery to repair. This is not hard to repair, but it does take surgery. Okay. The other one is cleft palate and cleft lip. Now over here in the drawing pictures, you can see one baby has a cleft palate. So structurally on the outside, he doesn't look all that abnormal. But if you look at the picture just below, you can see that the top part of his mouth is completely open. And we know from our anatomy classes that that's going to open up into sinuses. It's going to be very close to our brain. And so if this child gets too rambunctious, anything poking up through there could kill him. So left palate can happen without a cleft lip, but occasionally you will see those, or frequently you will see those together. So looking at the next drawing over, the one in the middle, where this baby has a cleft lip and cleft palate, and if you want to Google that and see just how horrific these can get, this one is fairly minimal compared to some of them. And then you see the photograph of the baby over on the far right that has both of those, and you can see how her mouth is open clear up into her nasal passageway, into her nasal sinus, so there's nothing there in between the two. So for these babies, taking a bottle, because to suck a bottle, their tongue has to go up and squeeze the nipple between the roof of their mouth and their tongue to suck the contents out of the bottle, or the nipple, and this poses quite a challenge for them, because when they do that, the milk can go into their sinuses, into their nasal passageways, down into their lungs. They have great risk of aspiration. This is a horrible thing, but it is corrected with surgery, and there are ways to help these babies survive this. But just understand you need to be pretty aggressive with your suctioning, and you need to be a little creative with your suctioning if you have a baby like this. The other thing that you're going to have to do is you're going to have to think about mom, because mom looking at her newborn baby and seeing this for the first time is going to be pretty traumatic for her. So you'll have to kind of get your composure together quickly and figure out how you're going to present that to mom quickly. Cleft lip is for the upper lip to close. Pierre-Robin syndrome is similar but a little different. It's a small jaw and a huge tongue in conjunction with a left cleft palate. So we have, and I should have put a picture up here, we have the cleft lip a lot of times, we have the cleft palate a lot of time, and then basically it looks like these babies have no chin. And they have this ginormous tongue, so the tongue's going to stick out. It has no place to go. And that's going to become quite an airway issue because the tongue is so big and has nothing to hold it up. Okay. So for us in our assessment, we're going to very quickly assess our newborn immediately after birth. We'd like to get that done in that first minute after birth. We want to record our time of birth, obviously when it's born. Do a quick little test, what we call an APGAR score, and get some vital signs on this baby. Number one thing we're looking at is respiratory rate. And what we want to see in these babies are a respiratory rate of 40 to 60. So if they're breathing 60 times a minute, don't get your panties in a wad. That's going to be normal. Because they're tiny little lungs. So it's kind of like a hummingbird. Their wings flap about a bazillion times a minute because they're so tiny. Tiny babies are the same thing. They're just, everything is faster and smaller. So they're going to be breathing, but what we're looking for is it regular once they get started? Are we getting chest rise and fall with it? Are we seeing their skin pink up with it? And do we hear any sounds? Are they wheezing? Is it rattly? Do we have crackles or rhonchi with this. And then we want to make sure that they're adequate. So we should see that skin pinking up right away. And it's a pretty drastic change on a newborn because they went from being no oxygen, and literally they are purple, going through this tiny squeezy tunnel, and then coming out, and they're kind of scary sometimes. But they should pink up immediately. Okay? If they don't, grab your BVM and start some positive pressure ventilations. But keep in mind, we can blow the lungs out of these little guys. So your BVM may just be squeezing that bag in, maybe half an inch on a tiny little infant bag. They're going to hold in their lungs less than what you can hold in your cheeks. So it's just little tiny puffs, and you just watch them for the chest. If the chest rises, we're good. Okay, we're also going to look for heart rate. Now I'm going to tell you what, these are hard to count, really hard to count. But we should count them. We don't want to rely on a monitor for this. So, if you can only count for 10 seconds and multiply it times 6, that's better than using a monitor for this. Typically, we're not going to have a monitor on these little guys. They're slick, slimy. Putting a monitor on them is not going to be very feasible. Putting a pulse ox on them is nearly impossible. So we're going to have to count. And the best way to do it is to use your stethoscope and listen and count the heartbeats that you hear. Okay. So we want 150 to 180 beats per minute at birth. Okay. After they've kind of slowed down and gotten their grips and started breathing, then we'd like to see that slow down a little bit to 130, 140. Okay. If they are less than 100, then we're going to start chest compressions, because that's putting our patient into bradycardic rate for their age. And if they're in a bradycardic rhythm, they're not going to be able to perfuse no matter how much oxygen we get into them. So we've got to keep that heart rate up if we stand a chance at getting them turned around. So look at their skin color. Okay. If we can get a pulse ox on them, we want to, but sometimes that can take forever. So if you can't, skin color is a great tool for that. And once their little extremities start to pink up, cap refill works very well for them. Okay. If we can get a blood pressure, we want it 60 to 90 systolic. 60 is fine. If you can get it anywhere in between there, you're doing good. And then we want to keep their temperature 98 to 100 degrees Fahrenheit, or 36.7 to 37.8 Celsius. Hypothermic babies don't do well, and they get hyperthermic really fast. So we want to make sure, absolutely sure. If you're delivering in an ambulance, you should be sweating. If you're delivering in a home and you're going to transport them in the ambulance, then you should have that warming up while you're delivering that baby in the house, because that back of that squad should be hot. So we're going to assign our new baby an APGAR score. We'll talk about that, what that includes here in just a second. So we're looking to do APGAR scars at certain points after delivery, but resuscitation is going to take precedence over that. So if you can give your baby a quick once-over and kind of remember what was there, you may be able to go back and assign an APGAR score to them after the fact. But if they need resuscitation, like ventilations and or chest compressions or oxygen, that's going to take precedence. If they're not pinking up and not doing well, we got to get them better. So the APGAR score just kind of helps us decide who's going to need routine care, who's going to be those babies of greater need long-term, and who isn't. So it's not like we're not going to be able to figure that out eventually anyway. It's just nice to have that APGAR score if you have time to do it. Okay. So here's what APGAR measures. It looks at their appearance, looks at their pulse, their grimace. Are they crying? We'll talk about this in a minute. Their activity and their respiratory rate. So that's the acronym APGAR. Okay. So it looks like this. Okay. we're going to measure it at 1 minute, 5 minutes, and then 10 minutes, I believe. So when we look at the heart rate, okay, if the heart rate is measured and they don't have one, they get a 0. If it's bradycardic or less than 100, they get 1 point. And if it's over 100, they get 2 points. Okay. We're going to do the same with respiratory rate. If it's absent, nothing. If it's irregular, weak, not doing well, they get 1. If they got a good vigorous cry and are breathing fine, they get 2. Okay. If they're flaccid and limp with their muscles, a 0. If they've got some flexation, say they kind of pull back a little bit when you stretch your leg out, they get 1. But when you stretch that baby's leg out and let go, they should pull it right back in immediately. So that would be a 2. Okay. So if you irritate them just a little bit, you get nothing. They don't get any points. If you get a weak cry or they kind of scrunch up their face and grimace a little bit, they get 1. But when you stimulate them or irritate them just a little bit, and they cry vigorously, cough, sneeze, do whatever, that's 2 points. And then skin color. If they're blue, and they stay blue, they don't get any. At 1 minute, if they've got acrocyanosis, so their limbs and things are blue, but their trunk is pinking up, that's a point. If their trunk is completely pink, they get 2 points. Okay, so we score, score them based on that. So the maximum points they can get, going back here, the maximum points they get, there's 5 categories. There's 2 points possible in each category, so they're, a perfect score is 10. So what we're looking for is a baby that's scoring 4 to 6 is moderately distressed. Okay, so we're going to need to oxygenate them and stimulate them. Okay, if they've got 7 to 10, they're fine. That first minute, if they're scoring 7 or above, they're fine. They're probably going to just pick right up from there and keep going. If they're less than 4, then we need to start CPR. We got to be really aggressive with this baby. So our treatment starts prior to delivery. We're going to prepare our environment, and most of the time this is en route even. If we know we're going to a woman in labor, we're dragging out that OB kit that we haven't opened in 6 months or a year and looking to see where things are. If you're not driving, you can grab that thing and start looking at it as you're going down the road. Get familiar with where your bulb sucker is. Get familiar with where your scalpel is, your blankets, your ET tubes and what size they are, and where's your syringe at, and those types of things. Okay. Then we're going to get that all set up when we get there so it's easily accessible to us. We want to make sure that our environment's clean, put mom in a place that is going to be a nice place for her to deliver, and also one that you could quickly bounce her over to the cot. Well, I shouldn't say bounce, that's not a good word. Move her over to the cot and transport quickly if you needed to. Airway management is going to be critical, so make sure you have your oxygen handy. Make sure you have a infant BVM. Make sure you have something for blow-by oxygen. Make sure you have several blankets to keep that baby warm and dry. Okay. And then always keep baby at the same level as mom's vagina. And we talked about this earlier. If you lift the baby all the way up to resuscitate, you are doing nothing more than draining the blood right back into mom, which causes all kinds of horrible issues for mom, as well as baby. So keep baby down low until that cord is cut. Here are some devices, DeLee suction devices that we use with our babies, especially if they've got meconium staining. So the DeLee suction we can put down like an ET tube or down in their ET tube or down in the back of their throat. It's kind of, you put your finger over the little port, your thumb over the little port. You hook the conical end by the port up to your suction tubing. And then you've got a nice little kind of a French catheter for suctioning. The one on the bottom in the blue is called a DeLee suction trap, and that actually works the same except the little trap will trap the stuff that you're suctioning out so you can actually see what it looks like rather than throwing it into the big suction container. So these are used a lot with our little ones. This is a meconium aspirator, and it's hooked up to your suction tubing the same way, and the thumb on that little port operates it. But it's designed to actually go down into the ET tube and suction through that ET tube to get the meconium fluid out of the lungs. Okay, so we're saying we need to give some supplemental oxygen if central cyanosis remains present in our little baby. Okay, so understanding they're not going to just be born and boom, turn pink. So give them a few breaths to see if we start making some improvement before you start getting your panties in a wad. So we need to keep them down low, we need to keep them warm, and then we need to start looking at the color and looking at their respiratory rate. If their breathing is erratic or they're just not pinking up, then hold a little blow-by oxygen on them, okay? And we'll see where that goes. Okay, this is circummoral cyanosis. So you see how pink and purple this little baby's hands are? That's nothing to worry about. Okay, what we're looking at is her trunk and her face. Are those pink? Okay, babies, when they're this little, they get cold real easy, and they get cyanotic in their extremities real easy, but they pink right back up. When you've got cyanosis centrally, that's when we really need to start worrying. So I want you to know the difference between the two. Okay, this is Parker. This is my grandson. And this is him at about a minute or two old. And you can still see he was perfectly healthy. He was a 9.5-pound little feller. He was born a week past his due date. And you can see here, just based on the skin coloring of his mom, how purple he still is. And he's no longer crying, so he's been born for a little, and it may be more than a minute. But he snuggled up to mom and did really good. But he was very purple here. And we weren't worried. Okay, here he is at 2 minutes. He's starting to pink up just a little more. And you can see he's got a good grimace on his face over there. And he's got that furrowed brow, and his brows are pinking up. But look at his cheeks are pink, and his overall appearance, he's starting to pink up. He's still a little cyanotic on his hands, but he's pinking up nicely. And here he is about 8 minutes, and then again about 20 minutes old. And see, he pinked up very nicely. He did not require any resuscitation. He didn't require any oxygen at all. Okay, and there he is today at 1 year old. And he's still got nice pink round cheeks, and he is completely adorable. And that's my advertisement for the night. Okay, so we need to suction our babies as soon as their head is delivered, okay, during delivery. And then we need to suction them when indicated. If they've got an obstruction and they're not spontaneously breathing, or you hear noises when they're breathing, then we need to suction them. Okay. Once we suction them, if you hear noises, suctioning is going to be first. Number one, it will stimulate breathing. Number two, when you do use your positive pressure ventilation, you're not pushing a bunch of stuff down in their lungs that's going to cause them problems. If meconium, and meconium, remember, is amniotic fluid that's tinged either brown or green, which means that the baby has had a bowel movement in utero. So when they were still in the amniotic sac, they had a bowel movement. And really good chance that these babies probably have that stool inside their lungs. If they have breathed any of that in their lungs or had that fluid get in their lungs, which it regularly does, but if the meconium, the stool, has gotten in there as well, then this baby could have some problems. So we need to think about tubing that baby, putting an ET tube down in, and using our meconium aspirator to suction those lungs out really good. Okay. So if our babies are, if you notice the meconium staining and you've got a baby that's just not responding well, think about intubating that baby. Okay. If he doesn't cry immediately, then we're going to just gently rub his back. You can rub the bottom of his feet. We don't hang him upside down and spank their bottom anymore. And we don't thump them anymore, but you can kind of run your finger up the sole of his feet. But oftentimes just rubbing their back, just hold their belly in your hand, flip them over, and just rub their back. Okay. Also, we've got to deal with evaporation. These babies are wet. Their heat is coming out and it's just rapidly leaving their body. They just came out of a 100-ish degree temperature and we're throwing them out here into 70 degrees. And it's a huge drastic change for them. They're wet. And so we've got evaporation, we've got convection, we've got conduction, and we've also got radiation. All four of those things are working against our baby. So once you get them out, immediately wrap them up. You can cut the cord after they're wrapped even, but get them out, suction their airway, make sure they're breathing, and get a blanket on them. Okay? We want to dry them off, and then we want to toss that blanket and grab a nice dry one to wrap them up with. So close all the windows and doors that are there, swaddle them up. And swaddling out, if you've not ever had a baby, is quite an art, but it's like a papoose. We're wrapping them really tightly. So not tight enough to like cut off their airway, but we're tucking their arms and legs in nice and tight. So wrap one corner of the blanket all the way around the baby's torso, arms, and legs, tuck it in. Bring the bottom up nice and snug so their feet are pulled right up into their body, and then bring the other corner back over their torso and wrap them up that way. Does two things. If you keep their body all scrunched up, that's easier for them to maintain their heat. If they also feel secure because they've been in that position for 9 months, so that helps them feel secure and settle down. If we get them not stressed out, their oxygen demand is going to be less, and we can make better use of the oxygen that we have. They absolutely do not have any ability to keep themselves warm at this point. So they are 100% reliant on you for that. Okay? And then make sure you cover their head, either with a warm blanket. You should have a little beanie cap in your OB bag. Drag that out and put it on because 75% of this baby's heat is going to be lost through his head. So get that covered up, dried off and covered up as well. Be very careful when you are drying off a baby's head. A couple things we need to do is we need to make sure that we support their head. They don't have any ability to hold up their own head, so we want to make sure we're always supporting their head. And then when you dry off the top of their head, they've got these fontanelles, and that's places where the plates of the skull have not yet grown together. So they're very soft and you can poke right into the brain. So be very gentle on those fontanelles, but just dry off the head and keep them warm. If you're in a cooler place, you can take your heat packs. It says here to place water bottles or rubber gloves filled with warm water around the newborn. I struggle with that because I think they're probably going to pop. But if you've got something like that you can, you don't want them to get wet again. So if you've got a water bottle that you could put in there that's going to stay sealed, yes, I think that's great. But another good place to do is put them right on mom's chest and wrap a blanket right around mom. Mom is a great furnace for this baby. She's been taking care of him for 9 months. So put him that skin-to-skin contact with mom and then wrapping something around him over the top of mom is a very nice warm place to be if you don't need to resuscitate. Okay. We're going to clamp and cut the umbilical cord. There's some talk out there that we have to wait until it stops pulsating. We do not. In EMT class, I think we do teach that a lot, but as paramedics, if baby's breathing and her heart is beating, she doesn't need the umbilical cord, so we're going to cut that and get rid of it. we'll talk a little bit about where to cut that in just a second. But we don't want to squeeze anything out of there. We don't want to milk it or strip it. If we do that and we push that blood back into mom or up into baby, we can cause all kinds of blood issues with them. We can also cause hyperbilirubinemia, which increases the bilirubin in the blood and causes jaundice in our kids. It also keeps the liver from starting to work in our baby. So our baby can become septic because the liver isn't properly filtering out the poisons and toxins inside the body. So we just want to cut it and clamp it. Okay. So 30 to 45 seconds after birth, remember we're keeping baby at mom's level. We're going to put 2 clamps on there and we're going to cut those. Now if dad's there and wants to cut them, I have no problem with that. It's a simple cut. Oftentimes that's kind of a big thing. So if that's what they want to do, that's fine. You just make sure that you're there to watch how that happens, and then periodically make sure that there's no bleeding on either end of that. Okay, so here we go, 10 centimeters up. They're saying 10 centimeters, 6 inches, about the same. And then another one, 15 centimeters, and then we're going to cut between the 2 clamps. That's going to free baby, but we're not done. Mom still has to deliver the placenta. We still have to make sure she's not hemorrhaging. We still have to make sure she's still with us and alert, get a blood pressure on her. We have lots to do with mom and lots to do with baby. So we're going to cut that so we can get baby freed up, to get him warmed up and put right up. If he's crying and acting like he should, put him right up on mom's chest, let mom hold him. She's been waiting a long time for that. Okay. So the distressed newborn, either full term or premature, could be one that we see the meconium staining. Okay. If they have that meconium, like we talked about, can cause lots of respiratory problems. And make sure when you deliver your report to the hospital, if you did see meconium or suspect it, that you let them know. Okay. So we're going to resuscitate with ventilation and oxygen if needed. One thing we're not going to do is give a baby oxygen that doesn't need it. This is where we very first found out that oxygen could be toxic, was in our newborns. And we're finding out that, or many years ago, we found out that newborns that got oxygen had learning deficiencies, had a lot of learning problems, ADHD, all kinds of neurological issues later in life. And that is what founded the studies for looking at how super high oxygen levels in adults affected us. And that's when we found out, based on those studies and scientific investigation, about free radicals. And that's helped us in adults learn that we need to regulate our oxygen in adults. So no oxygen unless they need it. Okay. The use of IV fluids, drugs, cardiac stuff really is hardly ever indicated. Okay. Suctioning, drying, stimulating, and keeping them warm are the things that's going to bring these babies around. The big thing that we're going to see is heart rates. Now, you maybe prior to delivering this baby be able to get fetal heart tones. That's kind of hard. You have to have special equipment. If when you get there they're delivering, you're probably not going to get fetal heart tones. But you can check that baby as soon as it's born. If they're less than 100, then you know you've got a baby that's in pretty serious distress. And so that's going to put them pretty high up on the ranks. So pulse of less than 60 is distressed newborn and treated with chest compressions. I think this is an error in this slide because it's a pulse of less than 100 per minute is a distressed newborn. So don't take this for granted here. Pulse of less than 100, we start chest compressions. We're going to monitor the heart rate manually. We're going to feel for a pulse or listen to heart tones. We're not going to try and hook them up to a monitor or pulse ox and get judged on that way because it most oftentimes will be erroneous. Okay. So We're going to have a bag valve mask. We need a bulb syringe, our DeLee suction, a meconium aspirator. We need a laryngoscope, and we got to make sure we have our tiny blades, size 0 to 1. And then we got to have our ET tubes, so 2.5 to 4. And then our suction catheters that we're going to need. In addition, you're going to need your blankets, your little beanie to keep them warm. You're going to need your clamps for your cord. You're going to need oxygen. You're going to need lots of things also. But in our kit, hopefully we have a stylet that's the size to fit our ET tubes. Babies' pharynx or vocal cords are very anterior, so they're going to be up high, and they are kind of hard to hit. So a stylet probably is going to play in your favor if you have one. Okay, we need a tape. Obviously, they're saying a laryngeal mask airway. I don't know if we need one of those or not, or if we carry one. The King LT actually has a very small one. I don't know if it's small enough for pediatrics or for neonates, but I believe there is one. An umbilical catheter, and in the state of Nebraska, this is not a paramedic skill, so we probably won't have one of those. But a 3-way stopcock, when we get into PALS here in a week or so, you're going to find out how to use that, and it's going to be very handy to have one of those. Okay. Then we need some syringes. We need some, they're using an 8 French feeding tube for gastric suction. Any small suction tube would work. We need a glucometer because we're going to check this baby's blood glucose. A blood glucose currently less than 60, and we're going to give them a little bit of D50, dextrose, not D50, I'm sorry, D10, dextrose 10% in water to get their blood sugar up. Now there are some new research coming out that's showing that babies with a blood sugar as low as 47 that are not treated for that low blood sugar are doing very well. So I think there's a chance that down the road we may see that level of blood glucose of 60 lowered a little bit, but I think that's the standard right now. Okay, needles and syringes, we need towels, we need epi, and we need some fluids, so probably your normal saline. Okay. So we're going to follow our inverted pyramid. I'll show you that in just a second. Again, simple maneuvers are the best. Very, very few of these guys require advanced life support measures. So dry them, warm them, position them, stimulate them. Whoops. But here's how this is going to work, okay? I get this. We're going to start at the top of this triangle. And you see the very first 4 steps in this triangle are basic. So we're going to dry them, warm them, position them, suction them, and that tactile stimulation is just rubbing their back or the soles of their feet. Okay. If that doesn't work, we're going to try a little oxygen, usually a blow-by oxygen. Okay. If that isn't quite effective enough, then we're going to go to our positive pressure BVM ventilations and chest compressions if needed. Okay. Most of the time, that's enough to get them kicked into high gear. Okay. If not, then we consider intubations, and the very last thing we're going to do for them is medications. Now, the medications that kids like very, very best is going to be epinephrine. So that's going to be your first medication for all kids stuff, unless they are tachycardic. Of course, then we won't give them epi, but everything else kind of gets epi. So that's our what we call our inverted pyramid of neonate resuscitation. And quite honestly, there's only like 1% that fall in the point of that pyramid on those bottom 2 levels in the advanced category. So to resuscitate, we're going to place our baby on the back with the head slightly below the body and the neck slightly extended. Okay. If our infant is not responding, if he's flaccid, then we're going to go to intubation and we're going to suction immediately. Okay, so here we go. for the distressed newborn, these parameters are, we're looking at respiratory rate, heart rate, color, and the APGAR score. So like we said with APGAR, if it's less than 4, we're going to think seriously about getting aggressive with this patient. Okay, so we're going to begin positive pressure ventilations. If the heart rate's less than 100, if they're not breathing at all, or if their SpO2 is less than expected, okay, or better yet, that we're looking at before we dink around trying to get an O2 on this patient, look for central cyanosis. If his face and chest is not pinking up, then we have a problem. We're looking at a normal ventilatory rate of 40 to 60, so that's kind of what we're going to do. We're going to ventilate them in about that 50 breaths per minute range. It's just tiny, tiny little breaths, okay? So don't get your natural instinct, because this is a really high stress situation, is to give them way too much oxygen. And please, please, please do not do that, okay? There's a little face mask. Make sure you have something that fits them. Okay. If we're doing any of the following things, we want to think about endotracheal intubation. So if we're doing chest compressions, we'll probably want to tube them, okay? If our patient can't be ventilated with a mask, let's say they've got a deformity to their face and we can't get a mask to seal, then we're going to tube them so we can get them ventilated, okay? If they've got a bunch of gunk down in their lungs, let's say they aspirated a whole bunch of yuck and they just can't breathe through it, and we're going to have to suction the trachea and or the lungs, then tubing is required. If we're going to be ventilating this baby for quite a while, if we think we may have a herniated diaphragm, then it's going to take that extra pressure from positive pressure to expand those alveoli at the bases of the lungs, especially with that diaphragm pushing up and the abdominal organs pushing up on the lungs. Babies have a really hard time opening up the alveoli at the base of their lungs, and that's why we like to see them cry really hard, because they suck in forcefully the air and it pops open those alveoli at the bottom of the lungs, which have never been opened before. So they're just laying there doing their thing, and it takes some effort to get enough air in there to get those opened up. Or if we've got inadequate respiratory effort, then we're going to think about tubing this baby. Okay. So as you can see here, we're going to insert the laryngoscope. As I said before, these vocal cords are sit very anterior. They have a very large head and a small neck, so it's hard to get through that ginormous tongue and all of that to get up there and see those vocal cords. So in with your tiny blade, you can see he's going kind of straight down in and then just lifting out. Okay, and there's your tiny little vocal cord right there. And again, we're using an uncuffed tube, so it's going to slide right down in there once you see it. Okay, and slide your tube right in. Okay, and there we sit. Okay, and you can see how nicely that uncuffed tube sits right down in that trachea. Again, with the adults, as with the adults, we can right main stem them. So listen to your lung sounds. If you only have lung sounds in the right, pull back just a little bit. Okay, use your uncuffed tube. Capnography is awesome with these little guys. It's going to give us great tube placement. We're going to possibly take our pop-off valve off of our BVM. If you've got a pop-off valve, you may want to take it off, because it may take a little more pressure initially, like I was saying, to pop open those alveoli, especially if you've got extra pressure from something, extra fluid in there, or pressure from the diaphragm herniation. Okay. If your kiddo has gastric distension present, if they have a huge belly, then we're going to put in an OG tube, an orogastric tube down in their mouth, down into their belly, or better yet, through their nose down into their belly to help get some of that extra air out. It's very easy to overventilate these people, so if that happens, we need to get that air out of there because that's going to cause problems. Okay. If central cyanosis is present, or our O2 levels are less than expected, obviously, we want to keep our O2 levels up. If we can get an O2 level, it's really hard on babies, really hard. But we'd like to keep their SpO2 up above 94, just like with everybody else, between 94 and 99 if we can. So if we can get our oxygen warmed and humidified, great. Probably isn't going to happen in the field, but once we get to a place where we can, we'd like to do that if we can. Again, chest compressions, if our heart rate's less than 60, absolutely less than 100, if that's what we're coming out to. We're going to use the encircled chest thumbs technique. So your fingers are behind the baby's back. Thumbs come up around the chest using both thumbs on the bottom part of the sternum to do those compressions. Okay, we're going to do compressions at 100 compressions per minute. And we're going to use positive pressure ventilation to breathe for them in between. So 30 to 2, 15 to 2. With our wee little ones, we can go more than that. But if you go 15 to 2, you're going to be fine. But sometimes some classes are going to teach you, and we'll cross that bridge when we come to it, that 5 and 1 is sometimes still the approved. But American Heart's telling us 15 to 2, so we're going to stick with that one. Okay. 30 compressions and 2 breaths. If it's one rescuer, 15 and 2 if there's 2 of you. Then reassess the heart rate, respiration, and skin color every 30 seconds. We're not going to wait a long time because we want to get them up and breathing on their own as quickly as we can. Oftentimes they respond very quickly to CPR. Okay. So if our heart rate comes over 100 a minute, we can discontinue our compressions. We've got them up where they're making the trend upward. We're going to let them continue. But keep watching them. They can digress also. Most cardiopulmonary arrests in newborns come from a hypoxia. So our initial therapy is going to consist of ventilation and oxygenation. When those fail, if we can't get them warm and dry and breathing, then we're going to consider some fluids and some medication, which is frequently epi. And here it says vascular access is managed readily by using the umbilical vein. With the invention of the IO, we don't need to catheterize the umbilical vein anymore. And it's you run the risk of lacerating their liver by doing that because that vein goes right up into their liver. And so in the state of Iowa, or state of Nebraska, that is not a paramedic scope of practice. And so we're going to go to an IO. It's easy, it's fast, it's a great target to hit. And then we have vascular access with our IO. We can give fluids and meds. All right, end of part 1. We'll tackle part 2 in just a little bit. But if you have questions, you know how to contact me. So thanks for listening, and we'll get back at this.